Hello friends, this is Dr. Karthikeyan. So today we will quickly see the medicine recall of INI CET 2024. First question, ABG of a patient with recurrent vomiting. pH 7.5, PCO2 50, bicarb 30. So as we know, ABG 2 patients is must even if it is INI CET or NEET. So better be prepared with this basic values, which is pH 7.35 to 7.45, single value 7.4, PCO2 35 to 40, single value 40, bicarb 22 to 26, single value 24. So here pH is increased more than 7.4, it is alkalosis. Next bicarb is raised 30, metabolic alkalosis. So it was a straightforward question. Metabolic alkalosis, and in vomiting your HCl will be lost, acid will be lost. At the end of the day, it will be metabolic alkalosis. Next, one more ABG was given in the patient where RBS was given to be 420 and pH was 7.34 and bicarb was 20. I couldn't recall the CO2 value. Sodium 135, chloride 93. So diagnosis. So here if you see, same from the first step, pH less than 7.35, so it is acidosis. Next step, look for the bicarb or PCO2. Bicarb is low, it is less than 24, so it is metabolic acidosis. So in metabolic acidosis, we should be seeing whether we should calculate the anion gap to tell whether it's high anion gap or normal anion gap. So what is anion gap? In our body, the number of cations will be always be equal to number of anions. Whereas the measurable anions, if you take, the measurable cations are even more larger. Like sodium occupies a larger extent, whereas the measurable anions like chloride and bicarb are relatively, if you calculate the total value, it is relatively lesser. So there is a gap usually, the anion gap. So this gap, how to calculate it? From this big tower, sodium minus the chloride and bicarb. So this is the formula for anion gap. So here if you calculate, it is coming to around 21, which means high anion gap, metabolic acidosis. Next, ECG question was given to you. A patient who is unresponsive, breathlessness, as well as hemodynamically unstable. Some term was given. Next, best step they were asking. So, see, hemodynamic instability means either it can be systolic blood pressure less than 90, altered sensorium, and if the patient is in acute heart failure. All these can be considered as hemodynamically unstable, as we discussed. So next best step will be what? So what is this ECG showing? First of all, what is the ECG showing? Any approach to a tachycardia ECG they are given. So first you are seeing heart rate. Heart rate, how to calculate? The distance between RR interval. If it is less than 3 large boxes, then it is tachycardia. Next, look for the QRS. 3 small boxes, the width of QRS, whether it's narrow or wide. If it is narrow or wide, then next step will be rhythm. Rhythm, the distance between RR in each segment. So here if you see, it is irregular. So irregular rhythm means only 2 differentials. What should come to your mind? One is atrial fibrillation, another is your multifocal atrial tachycardia. How to differentiate it? Look for the P waves. If you can't find any P waves, or if there is any fibrillary P waves, then it is atrial fibrillation. If you can find P waves and 3 consecutive P waves are of different morphology, then it is multifocal atrial tachycardia. Whereas in the other side, if you see narrow QRS with regular rhythm, if P waves are absent, then it is AVNRT or junctional tachycardia. Or if P waves are present, but it is in a greater than 2:1 manner, then it can be any atrial tachycardia, mostly atrial flutter with variable block can be there. Or if it is in 1:1 fashion, every P is followed by a QRS, it is sinus P, then it is sinus tachycardia. The ECG what they are given was atrial fibrillation, and they are told the patient is hemodynamically unstable. So next best step always will be to do DC cardioversion. So what more? So atrial fibrillation is always a hot topic if you consider any NEET or INI CET. So better be sure with all the treatment protocols of atrial fibrillation. If the patient is hemodynamically stable, you can go for either rhythm control versus rate control. And rate control, if the patient is having LV dysfunction, like if they are given in question ejection fraction is less than or equal to 35%, then you should be going for digoxin or amiodarone. If the patient has normal LV function, systolic function, EF, ejection fraction is normal, then your drug of choice will be beta blocker or calcium channel blocker for rate control. Note whether if they have given any hint of bronchial asthma or COPD where beta blockers are contraindicated, there the only option will become calcium channel blocker like diltiazem or verapamil. Next, rhythm control. Note this most important point. Rhythm control, class 1C agent as well as class 3 agents can be used for rhythm control. Then they have given one more question. Correct statement regarding atrial fibrillation. See, again they have asked atrial fibrillation. First is, I can't recollect it properly, the options. Rarely seen in heart with normal physiology, normal morphology. Actually, atrial fibrillation is common in valvular heart diseases as well as non-valvular heart disease. Even aging, obesity, smoking, all these are risk factors resulting in atrial fibrillation in normal hearts. So it is very common. And systemic hypertension is the most common cause of non-valvular AF throughout. So it can happen. It is not rare. Next, discrepancy in pulse rate and heart rate are reliable for diagnosis. Yes, that is the pulse deficit. If it is more than 10, then we have a clinical pointer towards atrial fibrillation. Next is, only digoxin is used for rate control. No, now only we saw the list of drugs used for rate control in LV dysfunction as well as in normal systolic function. Next is, cardioversion is must for all cases of atrial fibrillation. So this what the latest ESC guidelines as well as ACC AHA guidelines, which have given guidelines for atrial fibrillation, says cardioversion, be it DC cardioversion or chemical cardioversion, it is always reserved for if the AF onset is just less than 48 hours, recent onset, new onset AF, or younger patients where we're having normal morphology, heart with normal morphology, structurally normal hearts. So here we reserve rhythm control as must. But see, for patients like rheumatic heart disease, severe mitral stenosis or severe mitral regurgitation where the LA is hugely dilated, there if you do rhythm control by giving cardioversion, what can happen? It should not be done actually, because this dilated LA is a source for thrombus to settle there. Okay, so when you do cardioversion, what will happen? The rhythm changes from atrial fibrillation to normal sinus rhythm. So what will happen is, in normal sinus rhythm, atrium contracts properly, but in atrial fibrillation, atrium was not contracting. So whatever clot which is formed in the LA will be dislodged into the LV and it will be embolized, causing thromboembolic stroke. So risk of thromboembolic stroke is there if you do cardioversion, DC cardioversion or any cardioversion in a patient of RHD, those having structurally abnormal hearts. So here, like, cardioversion is must for all cases of AF. It's not a correct statement as per the latest ESC and ACC AHA guidelines. Okay, so answer should be discrepancy in pulse rate and heart rate are reliable for diagnosis. Next, the following correctly describes, which of the following doesn't describe accurate CPR? So first is chest compression 100 to 120 per minute, chest compression to a level of 2 to 3 centimeter depth, and allow effective recoil of the chest. And the last option was the rescue breath we'll be giving, which is 30 compression, 2 rescue breath. This was the question. This guidelines we discussed in rapid revision in speed. So first is like the protocol for ACC AHA guidelines. This is the CPR guidelines which is followed throughout India. Okay, so as per this, any cardiac arrest patient, first CPR should be started for 2 minutes, followed by you should check the rhythm in the monitor, whether it's shockable rhythm like VTVF or non-shockable rhythm like pulses, electrical activity or asystole. So if it is shockable rhythm, give DC shock. How much joules? Maximum joules which is available in the defibrillator, 120 to 200 joules. 200 joules if it is available, give it. Next is 2 minutes CPR followed by your shock. Then what are you going to give? You should give ADR, adrenaline should be given. Then again check the monitor whether it's shockable or unshockable. Shockable means give shock, again CPR. So third time what you should give is, you should keep amiodarone or lignocaine. Okay, this is the normal protocol. This should be continued till spontaneous circulation comes out. If it is non-shockable, only option is CPR, and then every 3 to 5 minutes you will be giving adrenaline, which is 1 mg, and amiodarone. First dose will be 300 mg and second dose will be 150 mg. So this you should be knowing. Next, we saw the guidelines also how to give CPR, effective CPR. Push hard and push fast. Push hard means at least 5 centimeter depth should go. Okay, and also push fast, meaning 100 to 120 per minute. This is the rate of your compression should be there. Next, what we saw in this was advanced airway. If it is in place, then your breath should be 1 for every 6 seconds, meaning 10 to 12 per minute. Respiratory rate should be 10 to 12 respiratory per minute if it is if you have intubated the patient, if advanced airway is in place. If you haven't intubated, then it is for every 30 compression 2 rescue breaths should be given. This is what was asked. And what you should see, you should check for return of spontaneous circulation. Best measure to assess it, this end-tidal carbon dioxide, which should be more than 40. Then also you should be seeing arterial line, after putting arterial line, whether the spontaneous arterial waveforms are coming or not. Next is to know the cause of cardiac arrest like 5H and 5T, hypoxia, hyperkalemia, hypokalemia, this acidosis, at the same time tension pneumothorax, tamponade, or thrombosis, pulmonary embolism or coronary thrombosis. Okay, so all these reversible causes, if they are there, then we should be starting to look for those causes and treat the patient. This is the CPR guidelines. Remember this, it will be helpful for your NEET exam also. To the centripetal adiposity, adipose tissue depositing everywhere, the skin actually gets stretched. Usually when a person gets obese, skin gets stretched and striae will be formed. But that won't be in purple color. Why purplish it is there in Cushing syndrome is, the capillaries are highly fragile, they bleed. And the blood will be digested and this will give this purplish tinge to the striae. So only we tell when it is purplish striae, and if it is more than 1 centimeter, it is more specific towards Cushing syndrome. Okay, whereas in all obese patients you can find striae, but it won't be purplish. If it is purplish means then the capillaries are fragile. That is leading to spontaneous bruisability as well as your purplish striae, which is more than 1 centimeter. And also proximal myopathy. These are the 3 most specific findings in Cushing syndrome. And obviously the moon faces, buffalo hump, and pedunculated abdomen, centripetal obesity, all these are classical features which are relatively specific for Cushing syndrome. And skin findings in insulin resistance, you can see acanthosis nigricans, which has the velvety patch around the axilla or nape of the neck. Okay, and also in hypothyroidism, the skin will be thick, dry skin will be there, hair fall, alopecia can be there. So all these things can be there in that. Then hypercholesterolemia, we can have xanthomas, xanthosmas, those are the cutaneous findings. A 10-year-old patient treated with antibiotics for tonsillitis presented later with history of swelling of face. Urine shows eosinophils and eosinophilic cast was found. Diagnosis: interstitial nephritis, pyelonephritis, UTI, lupus. Just see the options itself. They're telling he was treated with antibiotics for tonsillitis. Uske baad the patient develops swelling of face. So something to deal with the antibiotic induced, drug induced swelling of face, and eosinophils are there. That means it is allergies happening. So as we learnt in acute tubulointerstitial nephritis, 2 causes are there. One, it can be due to the bacteria itself, or it can be due to drugs. Most common is drugs only. What drugs? 2 most common drugs you should be remembering. One is NSAIDs and one is antibiotics. NSAIDs, the type of hypersensitivity is type 4, cell-mediated hypersensitivity. So the cells will be seen will be lymphocytes. Whereas in antibiotics, it will be type 1 hypersensitivity. So type 1 means what you see in asthma. It is eosinophils. So cells, what you can see is eosinophils. And since it is a inflammation will be following, so the interstitium will be involved, producing a characteristic pathological hallmark in biopsy, which is interstitial edema. Okay, so due to the interstitial edema, the kidney will be swollen up, producing to enlarged kidney in ultrasounds. Okay, and if you see the cast, this eosinophils can be excreted along with the proteinuric content, producing eosinophilic cast. So this you should be knowing. So treatment is mostly drug withdrawal itself will be settling, or else if it is going to the severe extent, then you can give steroids, because it is a type 1 hypersensitivity. Okay, yes. Next is patients with chest pain, fever since 1 month, breathlessness since 5 days, chest X-ray shows cardiomegaly. Correct statement are all except loud dysphonia, pulses paradoxes, emergency pericardiocentesis, in echo, diastolic collapse of right ventricle can be observed. So what are they trying to tell? Chest pain with fever since 1 month, breathlessness since 5 days. That means patient having cardiomegaly also. So that means the patient is having pericardial effusion, which was developing slowly, and since 5 days he is having breathlessness. Okay, he might be landing up in cardiac tamponade, and the options which are there are obviously showing that features of cardiac tamponade. So what only you should remember for cardiac tamponade? One thing is, see, the Beck's triad, which is the fluid accumulating around the right atrium and right ventricle. This will be compressing, and it causes pan-diastolic resistance. Okay, due to which what will happen? In diastole, blood coming from the RA to RV will be hampered. So descent won't be seen in JVP. It is the Y descent. Y descent is absent in cardiac tamponade due to pan-diastolic resistance. And in diastole, the RV can't expand to receive the blood from the RA. That is called what? Early diastolic collapse, which is the characteristic finding in echocardiography. ECG, you can have electrical alternance due to swinging of the heart in the pericardial fluid. You can swing back and forth, producing alternating QRS voltages. Next, this is the pulsus paradoxus. What is a pulsus paradoxus? What is a phenomenon here? During inspiration, what happens is the negative intrathoracic pressure allows the emptying of blood from the vena cava to the RA and RV. So RA and RV will be receiving maximum amount of blood. And during inspiration, blood will be pooled in the lungs also. So blood flow to the left side of the lung will be very low. So usually the systolic BP during inspiration, if you see in the picture, systolic BP usually decreases to some extent, but not more than 10 mmHg. Usually the fall will be there, but it will be less than 10 mm mercury. So what happens in cardiac tamponade is, what I told was, it was pan-diastolic resistance. Throughout the diastole, it has been obstructing the blood flow from the RA to the RV. So what happens, like whatever blood comes, it is like the interventricular septum shifts more towards the left to get the blood from the RA to the RV. So what happens, due to this, already the LV is underfilled, because RV is also taking a portion of LV to fill the blood from the RA. So what happens is the systolic BP falls even more than 10 mm mercury. Okay, this exaggerated fall of 10 mm mercury in cardiac tamponade is called pulsus paradoxus. Pulsus paradoxus is seen in cardiac tamponade. So already obviously this patient will be needing emergency pericardiocentesis, as well as in echo diastolic collapse is seen. Heart sounds will be muffled, but it won't be a loudest one. Okay, so that will be exception. Cardiac tamponade, again same, it's important for NEET also. Next is not a complication of hypokalemia. VTAC, cerebral edema, diabetes insipidus, quadriparesis. This also we discussed. Cerebral edema is always with complication of hyponatremia. Okay, and VTAC, if you see, hypokalemia, hypomagnesemia and hypocalcemia, all these electrolyte abnormality can cause QT prolongation, due to which VTs can originate. Okay, and also hyperkalemia can also cause ventricular tachycardia by prolonging the QRS, resulting in sine wave pattern and VT. So these are the electrolyte abnormalities causing VT. This is most important because they are reversible cause of VT. Okay, next is diabetes insipidus. Two electrolyte abnormalities should be remembering. One is hypokalemia and the next one is hypercalcemia. You would have known that hypercalcemia causes polyuria. Okay, why? Because of this only. The hypercalcemia will destroy the aquaporins present in the distal collecting duct for water absorption. Okay, so these two are causing diabetes insipidus, nephrogenic diabetes insipidus. Next is quadriparesis. Obviously, there is a condition called hypokalemic periodic paralysis, as well as there is a condition called hyperkalemic periodic paralysis. Both can result in quadriparesis periodically. When potassium is corrected, then the patient's tone will come to normal. Okay, so not a complication is cerebral edema. It is due to hyponatremia because of the effective osmol. Sodium is effective osmol. It drags water and keeps along with it in the circulation. But what happens in hyponatremia? There is less sodium. It can't drag water and keep along with it in the circulation. So what happens? Water tries entering into the cells, causing swelling of the cells. Mostly in brain, if the cells swell, it will result in cerebral edema, because brain it is contained in a cavity which it is not expandable. Okay, so what will happen? It will easily expand and it will cause cerebral edema, and only way where the brain can expand is to the foramen magnum, resulting in herniation and death. So cerebral edema is due to hyponatremia. 2 times they have asked the same drugs again and again. Diabetic with heart failure with reduced ejection fraction, drug preferred is always, you should be preferring your SGLT2 inhibitor, empagliflozin, okay, or dapagliflozin. UTI causing drug is again empagliflozin, because it causes glucosuria, due to which you can have fungal infections as a common side effect, and also UTIs as a side effect. Okay, yes. So that's it with part 1. We'll be dealing with part 2, medicine recall, in a short period of time. Okay, so I hope like the medicine recall from cardio and I hope the medicine recall helped you, and it's always good to learn these things before NEET, because whatever the areas which we focused for in medicine has been asked. Okay, so always believe this and try focusing on your basic concepts again and again. Thank you.